Our next talk is to be given by Dr. McNitt-Gray, and we're going to try and sort of introduce all the technical terms, make sure that we're all speaking on the same page, and that all the terms we use for the rest of the talk should be very consistent. And that's one of our biggest communication challenges, is that we all speak the same language. Okay, we're going to play with the lights for a couple of seconds just to try and make this a little bit more visible.
If the disco ball comes on, just go with it. Just go with it. Ready? Okay, here we go. I'm Mike McNitt-Gray from UCLA, and I was asked to talk about key CT parameters. And I'm going to do two things. I'm going to talk about what they are called, and I'm going to talk about what they mean, and talk a little bit about their impacts on dose, and a little bit about image quality as well. Here are my disclosures. And the purpose of this is to introduce some of the important technical parameters. I don't have time to go into all of them clearly, so this is just going to be a quick once through some of the key ones. And there's parameters that affect both dose and image quality. And I'm going to introduce you to the APM CT lexicon and show you how to get to that. And we're just going to use that to talk about the terms used by the major manufacturers. Okay. So here's one thing. This is in the slides. I hope you can read it. But, oops, sorry. Oh, no. That was back. Forward. That's the one I want. Okay. So from the APM website, you do not have to be an APM member to get to this, I believe. I think these are publicly available. So you can get to the lexicon by going to the apm.org website, go and click on the CT protocol button, and then you get this, and you see the lexicon, and it comes up with a PDF document. Oh, sorry, it's an Excel document. And it looks something like this. So this is going to help us figure out what these terms are and a little bit about what they mean, so that when I'm sure you all wondered, you have one of your manufacturers here on this list, and they all call it something. Well, there's a couple that call it the same thing, but if you wanted to know what a Scout on GE was called on a Philips system, it's here, or a Siemens system. And here's the generic term, the CT LOCALIZER radiograph. Okay? So this is a lexicon. It's sort of the Rosetta Stone, if you will, to translate across different manufacturers what these terms are. And I'm going to use this a couple different times in the presentation. Okay? So, so I'm going to go through just these parameters. The CT localizer radiograph, that was that bottom line, the Scout or Topogram or a Surview. KV, MA, MAS, effective MAS. I bet some of you have some questions about this. We'll talk about pitch and whether it does or does not decrease dose. And finally, just a few words about tube current modulation, just to introduce the concept. Mark Stepanich is going to go through it in much more detail, but I'm going to introduce just a couple terms there. Okay, so let's talk about the first one, the CT localizer radiograph. It's the scan projection radiograph acquired by the system to allow, typically we use this to let the user prescribe the start and end locations of the scan range. Okay? What you may or may not know is that it's also used by all automatic exposure control systems. That's where it's used to plan the adjustments based on the patient size or attenuation. So it plays both roles, the typical that we're used to, start and end location, but it also is used to determine the patient size. Okay. So, for example, here is a slide that I've gotten from Siemens. Here's the radiograph, and obviously you can see the lungs and the abdomen and the pelvis. And what they do is they do some calculations based on that of the attenuation from the lateral point of view and from the AP projection. Okay? So they'll use this to estimate the amount of tube current modulation that they'll have to use to adjust for the patient size. So this is a very important piece in that system. That radiograph has a bunch of different names as we went through. This is a little larger scale for you. So the generic name is the radiograph, and Scout for GE, Surview for Philips, Topogram for Siemens, Scanogram for Toshiba and Hitachi, and there's a Surview and a Scout again. Okay. I put a placeholder here to say centering is important when you do the CT radiograph. Mark is going to go through that in a little more detail to show you some of the implications of if the patient is not centered, either they're too high in the gantry or too low, that has some implications that are going to trickle down to the automatic exposure control system. So this is just a reminder to pay special attention when Mark talks about that. Okay. You ready? Here's our first Sam's question. Oh. Okay, I'm going to read it, but I won't say go yet. But get your clicker ready. So each manufacturer has a different name for the projectional image that is used for planning the CT exam, including Scout, Surview, Topogram, Scanogram. But the generic name is actually the planning view, the CT localizer radiograph, the CT survey projection, the localizer scan, or the monitoring scan. Go. Am I supposed to hit go? Yeah. Okay, Garrett, you got 10 seconds. Okay. Now I hit go? Okay. And how'd we do? Okay, so 81% of you said number 2, and there were some other people who guessed some of the other answers. So the correct answer is number 2, the CT localizer radiograph, okay? The other ones are convincing, I think, distractors. At least some of you got fooled by that. So, okay, but it's a CT localizer radiograph. Is a generic name. Oh, my slides are right down there. Okay, let's talk about another technical parameter, the KV. What is it? It's the tube potential. Literally, the electric potential applied across the X-ray tube to accelerate electrons across a target material, expressed in units of kilovolts. Okay? In case you wondered what that KV was doing there. It's often reduced in peds or smaller patients. KV selection methods are now being incorporated into that class of tools called automatic exposure control. So some systems have that. I won't be able to go into those in detail. But I do want to point out, because I've heard some people say, oh, this is KV modulation. It is not. It is KV selection. The KV is constant through the scan. There is no KV modulation or varying of the KV within the scan. It is just KV selection. Okay? Let's make sure we get that. Most of the manufacturers have now switched from KVP, which is a term that we were used to for many years, to just KV. And the reason for that is they mostly believe that the KV is constant. These now, the generators are all basically switched, high frequency switching, and the KV is essentially constant. It's not the ripple rectified wave that we used to see. Okay, what does it do? Okay, well, it does affect the contrast in the image. The lower KV can give more contrast, especially when using iodinated contrast agents to exploit that closeness to the K edge. So we'll often see KV reduced or selected, a lower value selected for small patients or when iodine studies are used, contrast studies. However, when you do that, the tube output is also reduced when you reduce the KV. That is, the output per MAS is reduced. So that lower KV yields a lower tube output. That means the noise is going to increase. And so what happens often is that when KV is reduced, that often involves increasing the MAS to offset that noise increase. Okay? So in other words, if you just change the KV and leave the MAS where it is, you'll drop the dose significantly. We'll talk about that in a second. But you'll also increase the noise significantly. And to compensate for some of that, you may bring the MAS back. Okay? The KV selection methods will actually do some of that for you. They'll reduce the KV, but they'll bring the MAS back up a little bit. Okay, for dose, the CTDI vol is typically, and this varies a little bit, but let's pick a number. It's proportional to the KV to the power 2.5. Okay, it's not, don't take that too literally. Don't criticize me. No, it's really 2.2 or 2.6. It's 2.5 approximately, and it varies across systems and across bow tie filters. But the point is, if you reduce the KV from 120 to 80, then you get this ratio of savings. Okay, so you get about 0.36 of the original. So you get a 64% reduction if you keep everything else constant. Okay, if you just change the KV from 120 to 80, the dose will go down by 64%. If the MAS is held constant. In those KV selection systems, those automatic exposure controls, that MA may not be constant. Okay? So don't be surprised if you use that, like Care KV on the Siemens, and you see a higher MA, you'll notice that sometimes and say, don't be surprised, but the KV has been dropped. Okay? So there's some compensation there. Okay, one more. Here we go. Okay, next parameter, the tube current. And lots of things are at play here. We use the tube current in milliamperes. Sometimes we use the tube current time product in milliampere seconds. Some manufacturers use the effective tube current time product in a term called effective MAS. And that's defined as the MAS, just like there, the tube current time product, per slice. That's what one manufacturer uses as another term, effective MAS or MAS per slice. They're both defined as MAS divided by pitch. Okay? So that's a normalized term. Okay? And we'll talk about that in just a second. So here is, from the lexicon point of view, here is a map to which manufacturer does what and under what conditions. So, for example, Philips and Siemens use MAS for these axial scans, but they'll use effective MAS or MAS per slice for helical scans. Okay? So you may see both on your user interface. Sometimes you'll see the MAS if it's an axial scan. Sometimes you'll see effective MAS or EFF.MAS. Okay? Okay, next, Sam's question. We ready? Good. Okay, so the manufacturers use different terms for the tube current time product, or the effective tube current time product. And the definition of effective tube current time product is the number of electrons accelerated across an X-ray tube per unit time, expressed in units of milliampere. The product of tube current and exposure time per rotation, expressed in units of milliampere seconds, or MAS. In helical scan mode, the product of tube current and rotation time, expressed in MAS divided by pitch. In axial mode, equal to the tube current times the scan angle divided by 360 times the rotation time. Or in helical mode, equal to the tube current times rotation time. Again, we're talking about the effective tube current time product. Ready? Go. Oh, I should give an answer too, huh? Okay, let's see how we did. Good. Okay, a couple of you got distracted, which is understandable. Okay, that's sort of the point. But most of you got it right, okay? Okay. It is confusing. That's why we put the lexicon together. Okay, and the answer is number 3. It's MAS divided by pitch, also known as MAS per slice in some systems. Okay, let's talk about pitch, the next parameter. Pitch is the table feed per rotation divided by the nominal beam collimation, or in the ACR language, for the ACR accreditation system, is increment divided by NT. We'll go through some examples of this in a second. It influences the total scan time. Higher pitch, shorter breath holds, shorter scan, for example. It influences the dose. Oh, question mark here. Let's see what that's about. It does influence the effective width of reconstructed image thicknesses. That's a minor effect in most multi-detector CTs, but there is some effect in some scanners, so I had to throw it in there. Okay? Okay. Now, here's the thing that I really want you to remember. Pitch only influences dose if everything else is held constant. Okay? If all you do is change the pitch, but everything else is kept the same, then dose will be affected by pitch. Okay? What happens is sometimes these things happen outside of your view, and it's not clear from the user interface. So I learned that this slide is slightly incorrect, but that's okay. It's close. GE and Toshiba use MA and pitch independently. So if the pitch is increased, the CTDI vol will go down, and patient dose will also go down. Okay? Toshiba, that's not 100% true, but it can be true. Okay? So there, you're going to have to look at your user manual on that one. So I wish it were always true, and I gave us the whole truth. Philips and Siemens, they use the concept of effective MAS or MAS per slice. Okay, so if you're on the user interface and you have effective MAS and you say it's 100 and you change the pitch, okay, did everything else stay constant? Well, it turns out that effective MAS is MAS divided by pitch, and what the system does behind the scenes is keep that constant. Is if pitch changes, it changes the MAS. to keep that effective MAS constant. Okay? So not everything else remains constant. So it violates that here. So changing pitch in this system does not save you dose. The system automatically adjusts MAS with changes in pitch to provide a constant effective MAS. So if pitch is increased, then the MAS is also increased, and there's no change in CTDI vol. Okay? So I'm sorry, that's the state of our industry and our practice right now, so that pitch is inconsistent. On some situations, it does change the dose. In other systems, it does not. But that will be reflected in the CTDI vol, either pre-scan or post-scan. So you can see that. Okay? Okay. A couple more technical parameters. Collimation. Sometimes known as detector configuration, sometimes known as collimation. What I mean here is the nominal collimation, or the number of detector channels, times the width of each detector channel. For example, 64 by 0.65. The total nominal beam width would be the product of those two, or 40 millimeters. The actual beam width would be wider. Okay? But we usually don't have that information on the user interface. So we're going to refer to it as the nominal collimation. All right, what effect does that have? Sorry, we'll get back to the effects in a second. What is it called? Luckily, it's mostly called the same thing. I shortened this from the lexicon because I couldn't get all the words on there. But detector configuration is either called detector configuration or collimation by all the manufacturers. Actually, Siemens calls it, whoops, sorry about that. Siemens calls it acquisition. Sometimes it just says ACQ next to it there. Okay? All right. Changing collimation has some influence on dose. Sometimes it can be larger effect than others. The wider collimation settings are usually more dose efficient. So here's an example of some measurements we made on a system some years ago. And here, these are all done under the same conditions of a CTDI W measurement in milligray per 100 MES. So it's all normalized. So the only effect here is of changing the nominal collimation. So with the widest collimation, you had the least amount of dose. Okay, 8.5 milligray per 100 MES. If you go to the next widest, just one step down, 32 by 0.65, it goes up a little bit. Okay, so not much difference between the total 40 millimeter and the total 20 millimeter beam width. Okay, but as you continue to narrow that collimation, you start to see more and more differences until you see at the very narrow collimations that can be very dose inefficient and have quite a significant jump over the widest collimation. Okay, so generally, depending on the application, we try to go for the widest collimation setting possible and feasible for that application. Okay? All right. The last part I'm going to talk about is the tube current modulation. I'm just going to introduce this a little bit. Okay. As I mentioned before, this CT localizer radiograph is used in the planning of the automatic exposure control, the tube current modulation settings for this system, no matter which manufacturer it is. They all base it off of the localizer radiograph. And what happens is, this is what ends up happening. This is from a Siemens scanner where we actually got a hold of the actual MA instantaneous data and plotted it versus a sort of a longitudinal sagittal view of this patient. So you could see how much it varies. Okay? This isn't readily apparent on the scanner. It's not displayed to you. In fact, I'll show you what is displayed in just a moment. But the tube current is varying quite a bit here. Up in the shoulders, down through the lungs. Look at that. We're up here in the 500 MA here and down to 100 MA here. Factor of 5 difference from the peak tube current through the shoulders down here through the middle of the lungs. Then it comes back up through the abdomen. Okay? All right, what do you get to see? You get to see one number. You get to see in the dose report, this is from the patient protocol page from Siemens, you get to see the quality reference MAS that we had set for this patient. And the MAS here, that 176, is the average across that entire scan. It's one number. That's the average across that really significant variation there, okay? Just so you know, that's what's going on there. The CTDI vol that's reported is based on that average number, okay, for the most part. There are some exceptions. Toshiba has some software versions where this CTDI vol number is based on the maximum, but they've changed that. You'll have to, again, look at your user manual or contact the Toshiba folks about which software version you're using. Okay? So when tube current modulation is used, the CTDI vol reported is based on, again, mostly true, but not absolutely true, but it's based on the average MA used throughout the scan. Okay? Almost always true, but there's some exceptions. All right, so what does that mean? All right, so here is another patient, but similar concept. Here's a chest. very high through the shoulders, comes down through the lungs, goes up through the abdomen. If you were to look at the DICOM header and look at tube current values in each of the images in the DICOM header, you would see the curve in red. Okay, so that would reflect some of that variation along the longitudinal axis of the patient, but not the individual swings within a rotation. And the yellow line is what gets reported to you in the dose report and the patient protocol page. Okay? So, tube current modulation has lots of different names. Siemens calls it CareDose 4D. GE has lots of different version names, because they're different things. Smart Scan, Auto MA, Smart MA. Philips has DOM, that's an acronym, but I can't remember, I'm sorry. Something about dose modulation. And Z-axis DOM. Toshiba has Sure Exposure and Sure Exposure 3D. This is in the lexicon as well. And let me go through just a couple of examples of what the kind of things that vary, and then we'll talk about the kind of things that you need to pay attention to. Siemens, their CareDose 4D, that's the basic curve that I showed you before. The user sets what's called a quality reference MES. This system also uses online modulation. That is, they use the information from 180 degrees before to predict how they should modulate the current for the next 180 degrees, okay? They don't do that. That doesn't account for the size of the patient. It's just modulating from the lateral to the AP, I'm going to get it right. Okay, lateral, PA, to the next lateral, and to the, I got it wrong again, didn't I? Okay, if I do it this way, is that better? Okay, lateral to the AP to predict what's for the next lateral and the PA. Did I get it right that time? Okay, good. All right, okay. I'm just going to skip that part next time. Okay. So the MAS or effective MAS that would be used on a standard size patient, that's what the quality reference MAS is. What MAS or quality reference, what MAS or effective MAS would you use on a standard size patient? That's the value that you're being asked for the quality reference MAS. And then it'll modulate from there. The quality reference MAS is not, I repeat, is not the maximum nor the minimum in this case, okay? It's not. So if you think you're putting 250 in there and saying don't go above that on a Siemens system, that's not correct. That's not what it's meant to do. So that's not what it means. The actual MAS or effective MAS can be larger than this, and it should be for larger patients, okay? You're saying this is what I want for a standard size patient. For a larger patient, I do want that to go up. I want better image quality than what I would have gotten at that same MAS. It can be less than this, effective MAS, that quality reference MAS, for smaller patients. So that's why, and you see that in that dose report that I had there, let's see, you'll see, here's the quality reference MAS, and here's the actual average MAS. And that probably means that patient was smaller than average, smaller than standard. Okay? All right. So just be aware of what that term means. All right. In GE, they use a smart MA. There, the user sets the maximum MA, the minimum MA, and the noise index. And the noise index is approximately meant to represent the standard deviation in a 20 centimeter water phantom scanned under those conditions. Okay? So it's a reference value for you. The higher the noise index, the lower the MA. Okay? You're allowing the scan to have more noise, you can reduce the MA. And the other way. If you lower the noise index, you'll raise the MA. Okay? That's the intention there. The scanner input is influenced by a number of things, including the reconstructed image thickness. And I'll refer you to Kalpana Kanal's article in AJR in 2007. And I think I have that, I'm not sure if that reference is in there, but I hope you'll be able to find that, where she goes through and shows you how the noise index can be affected by the how the noise index interacts with the reconstructed image thickness to change the output of the scanner. This system tries to keep the noise constant across the patient size and anatomy. Okay, so our third and final SAMS question is, while all tube current modulation systems base their calculations from the CT localizer radiograph, which you got right in the first SAMS question, the image quality reference parameters vary from system to system. Which of the following will result in an increase in dose? Which of the following will result in an increase in dose for a patient of a given size where the scan is being performed with an automatic exposure control? Okay? Which is going to increase the dose? if you decrease the noise index on a GE scanner, if you decrease the quality reference MES on a Siemens scanner, if you increase the standard deviation on a Toshiba scanner, or if you increase the standard deviation or percentage on a Hitachi scanner. There's their image quality parameters. Ready? Go. Almost there. Okay, ready? Here we go. Excellent. Well done. Okay, a couple of you got confused. Actually, I would have expected more of you to be confused by this. So you did very well. Good. Okay, the answer is correct. The correct answer is number 1, decreasing the noise index on the GE scanner. Okay, so let me summarize. I hope we introduced you to some of the important technical parameters that affect radiation dose and image quality. We talked about the effects of the localizer radiograph, the KV, the MA, or that trio of cousins, the MA, MAS, effective MES. We talked about the role of pitch and how it sometimes does and sometimes does not affect dose, and tube current modulation or automatic exposure control. We've described some of the terms used by major manufacturers and some of the similarities and differences between them, and I hope I've at least pointed you to a very useful resource, which is the APM lexicon. And I think that's it for me. Thank you.
So we have maybe, since nobody's jumping up to the mics, I'm going to ask a question. I'm pretty sure I heard somebody from Siemens say once that the standard size patient that the quality reference MIS is based off of is the standard man who is 5'8", male, 20 to 30 years old, and weighs about 150 pounds. This guy, never goes into my CT rooms? Never? Is that the correct interpretation of what the quality reference MES is supposed to size to?
Yes.
Okay. So just making sure everybody's aware of that. Yes.
But we do get some of those where we are. In fact, like I showed you, we do have patients that actually the quality reference MES or the actual average MES is lower than that. So we do get some of those smaller patients.
I have a question about the reference mass for Siemens. So based on a 70 kg patient, is the scanner measuring what would be the attenuation? Yes. And based on that, this should be the right mass? That's, say, for example, 250. Is that right?
So I think I heard the question right, which is the question was the reference is based for Siemens and their CareDose product. The reference is based on a 70 kilogram patient. Mm-hmm. But the actual estimate of the patient size is based on the CT localizer radiograph or the Topogram in Siemens. So that's going to make the adjustments to say this is a larger patient, we need to bump the MAS up. Okay? So the actual MAS up. And by the way, there will be some constraints on that, right? Because what's one of the limitations? The instantaneous MA is limited by the generator, right? So sometimes what people will do for strategies is I showed you that tube current function going up, in that case up to 500 MA and clipping there. In some systems you can go much higher than that, but it may be instantaneously clipped and there may be ways around that. In other words, by, for example, slowing down the rotation time or decreasing the pitch. Those are also things that can help bring the MA down. Yeah. But does that answer your question?
So when the unit is installed at an institute or at a facility, so if it's the same Siemens unit, it should be the same reference mass for that specific exam? Would that be right? Or the radiologist actually tells the application what the reference mass should be based on what they like?
So this is a little embarrassing asking me to answer this question, but I know there's some Siemens folks in the crowd, but they can comment if I get it wrong. Do you want to answer it, Mike? Yes.
Okay.
Depending on the capability of the scanner.
Okay, understood. Thank you.
Okay, so I'm not sure if you all heard that. Did you all hear that in the back? No. Okay, so let me see if I can paraphrase, and if I get it wrong, then I'll be corrected by Siemens and Monochrome. The quality reference MES does not need to be adjusted by patient, but it should be adjusted by clinical indication or the purpose of the exam. So the idea is to maintain an image quality across an individual exam. So if you're doing a routine CT abdomen and pelvis, that quality reference MES should work for patients of different size. You don't need to adjust that. But if you're doing a high-resolution chest, then you may look for a different quality reference MES setting. Certainly we think about this, we think about it differently for pediatric patients just because we want to be very aggressive there. But I think that's what you were getting at, that you want to change it by indication and by image quality, not necessarily to adjust for patient size. That's what the system should be doing for us. And somebody had a question and then retracted it. So, okay. How'd I do? Is that okay? Okay.
Okay, thank you very much.